Welcome to the ACMG Knowledge Nugget on newborn screening for Pompe disease. This activity is intended for educational purposes only. Neither I nor the Planning Committee have any disclosures. This session is approved for 0.25 CME. To obtain CMEs for this activity, you will need to pass the quiz with a score of at least 80% and complete the evaluation. This session is a companion to the Pompe Disease ACT Sheet, which is freely available at www.acmg.net/ACT. ACT sheets are intended to be immediate resources for providers who encounter positive newborn screening results. Please keep in mind that a newborn screening result is just the first step in the diagnostic process. Further testing and evaluations are needed to determine if the newborn has the disease, a true positive result, or is unaffected, a false positive result. The ACT sheets are intended to provide an overview of the diseases identified by newborn screening and clear next steps for the management of a positive newborn screening result. This session will cover background information on Pompe disease, including clinical features and the underlying genetic cause, actions a primary care provider needs to take upon receiving a screen-positive test result for Pompe disease, clinical considerations, and supplemental resources. Pompe disease is a lysosomal storage disorder caused by pathogenic variants in the GAA gene, which leads to a decrease in acid alpha glucosidase enzyme activity. This decreased activity results in the accumulation of glycogen, especially in cardiac and skeletal muscles. The presentation of Pompe disease is clinically variable and ranges from a rapidly progressive infantile form to more slowly progressive later onset types. In the infantile form of Pompe disease, symptoms usually begin within a few months of life. Early symptoms include macroglossia or an enlarged tongue, muscle weakness, poor muscle tone, hepatomegaly, respiratory issues, and cardiomyopathy. Those with later onset Pompe disease will have much slower progression of disease symptoms, such as muscle weakness in the legs and muscles that control breathing. The later onset form does not usually involve cardiac symptoms. Pompe disease is inherited in an autosomal recessive manner, meaning that only infants with a pathogenic variant in both of their GAA genes will be affected. Parents with a child with Pompe disease are carriers and are unaffected, but have a 25% recurrence risk for any future children they have together. At this time, not all states provide newborn screening for Pompe disease. A good resource for checking a state's newborn screening panel is the newbornscreening.hrsa.gov website. In the states that do screen for Pompe disease, testing is generally performed by examining levels of the acid alpha glucosidase enzyme, which is decreased in individuals with Pompe disease. Some programs also examine the levels of creatine and creatinine or do gene sequencing as an additional tiered test to help improve screening, differentiate between types, and rule out cases of pseudodeficiency. Pseudodeficiency, commonly seen in lysosomal disorders, is caused by certain variants in the GAA gene. Pseudodeficiency means that an infant's acid alpha glucosidase enzyme levels appear low upon testing, but this decreased activity does not cause disease. These infants do not have and will never develop Pompe disease. Now that you have an understanding of what Pompe disease is, Let's talk about what to do if you have a patient screen positive for Pompe disease during newborn screening. You will need to take the following actions. First, contact the family and do the following. Inform them of the newborn screening result and that more testing is needed to determine if their child does or does not have the disease. Ascertain clinical status, paying close attention to signs like muscle weakness, breathing problems, and feeding difficulties. Provide the family with basic information about Pompe disease. Second, take a family history. Because Pompe disease is inherited in an autosomal recessive manner, it is common for there to be no known family history of Pompe disease. Third, arrange an immediate referral to a Pompe disease specialist for genetic counseling, a comprehensive clinical evaluation, and discussion of treatment options. The specialist is typically a pediatric geneticist. The clinical evaluations should include a comprehensive physical assessment by an experienced Pompe disease specialist. Fourth, working with the appropriate specialist, take steps to ensure biochemical and/or molecular confirmation of the newborn screening result. Confirmatory testing includes acid alpha glucosidase enzyme analysis, urine hexose tetrasaccharides analysis, and GAA gene sequencing. GAA gene analysis may help predict severity and outcomes. Fifth, report the final diagnostic outcome back to your state newborn screening program. The only available treatment option for Pompe disease is enzyme replacement therapy. This treatment is most effective if done as soon as possible in the infantile form and at the first signs of muscle weakness in the later onset forms. As you continue to care for your patient with a positive newborn screen for Pompe disease, it is likely additional questions and concerns will come up. Here are some resources where you can obtain information on Pompe disease, appropriate laboratories and tests, and genetic specialists. Before we end today's session, let's have a quick review. First, Pompe disease is a serious condition, and identification of affected individuals is essential for administration of early treatment. Second, newborn screening may identify the various forms of Pompe disease. Third, ACT sheets are freely available on the ACMG website to review in the event of a screen-positive result. In addition to Pompe disease, ACT sheets are available for many other conditions that can be identified through newborn screening.